such a privilege to be here. Thank you very much to the Mann Foundation for doing this incredible think tank and for all the work that you are doing to bring knowledge of the first 3 years of life to all of us. I was asked to talk about interventions, and as I was listening to the marvelous presentations this morning, I was marveling yet again at the theme of feedback loops. And I was thinking that yet another feedback loop is the feedback loop between scientists and clinicians, where science often confirms clinical strategies that have been evolving over the last 100 years, and in turn, science gives clinicians new ideas about how to streamline our treatments and how to make them more effective. As I was preparing this talk today about dyadic interventions, I came across an old book that some of them might be familiar with. It's a book by a gifted cartoonist called Gary Larson, who, in the dedication of his book, The Far Side Gallery number 4, wrote, "When I was a boy, our house was filled with monsters. They lived in the closets, under the beds, in the attic, in the basement, and when it was dark, just about everywhere." This book is dedicated to my father, who kept me safe from all of them. With an artist's intuitive knowledge, Larson was describing the inner life of infants, toddlers, and preschoolers, what Selma Freiberg called the magic years, where the child has an immature logic that makes him think that his thoughts and wishes actually make things happen. And the parent's capacity or incapacity to protect them is a reflection for the child of his or her own lovability or unlovability. And that is what dyadic intervention is about. Including parents in intervention increases and makes a big difference in the effect size that Dr. Fox was talking about of the interventions that we do. And this is because young children are capable of feeling stress and fear and are preoccupied with danger and with ensuring their survival and well-being from the time they are born. And their sense of safety depends greatly, as we heard, on how their parents respond to them. They are already grappling with the great questions that first emerge in early childhood and stay with us for the rest of our lives. Namely, will you stay with me? Will you keep me safe? Will you love me? Am I good in your eyes and therefore in my own eyes? These universal normative fears were first discovered and taught to us by psychoanalysis, and later developmental research has confirmed them and give them specific timetables and mediators and moderators, but they go back 100 years to what Freud first taught us. And it is when parents respect the child's fears and act to banish these metaphorical monsters from under the bed that the child's development can unfold in the solid foundation of the parent's protection. Now, we need parents to be helped to do this when they cannot do it by themselves. And for infants, toddlers, and preschoolers with emotional problems, relational or dyadic treatments are the most effective interventions. These are when at least one parent and the young child are seen together in a therapeutic format, and when the parent is helped to learn to read and respond to the child's objective needs, but also to their subjective experiences, fears, and wishes. In the past 20 years, we have blended the art of psychotherapy with the rigor of science by conducting many randomized control studies that consistently show improvements in the child's quality of attachment, behavior problems, and even cognitive performance. All effective treatments share the goals of promoting what we consider the three main facets of mental health: capacity to regulate emotion and recover from dysregulation, capacity to engage in trusting relationships and repair inevitable conflicts and mismatches, and capacity to explore and learn and cope with the inevitable frustrations of disappointment and failure. In every intervention, we need simultaneous attention to the light and the shadow, to strengthening and to also responding empathically to what hurts. Real-life events play a large role in emotional problems, and reality can be very hard for young children. In the first 5 years of life, they are more likely than at any other age to be physically or emotionally neglected or abused, to watch the marital conflict between their parents or even domestic violence, and last but not least, and this is often forgotten, to be injured and hospitalized by the trial and errors of exploration that include falls, burns, near drownings, dog bites, or poisonings that can be accidental or the result of parental neglect. A recent population survey by David Finkelhor and his colleagues, done by random telephone dialing with a high percentage of middle-class parents as respondents, showed that 1/3 of the children birthed to 2 years old whose parents responded had experienced at least one traumatic event in the previous 12 months. And this same picture that suffering does not spare any social class, it cuts across social classes, is shown to us by the monumental ACE study, the Adverse Childhood Experiences study, which was done jointly by the Centers for Disease Control in Atlanta and Kaiser Permanente in San Diego, where 18,000 patients, primarily white, 85% white, primarily middle class, all of them employed, all of them with health insurance, responded that only 35% of them had had no traumatic event during their childhood. 2/3 of them had had at least one traumatic event, and about 15% had had 4 or more traumatic events while growing up. And this is a highly privileged population. These data are very important because as the longitudinal follow-up of these patients continued, the investigators found out that people that had 4 or more traumatic events while growing up were exponentially more likely to suffer from the 10 leading causes of early mortality, including cancer, ischemic heart disease, and many other conditions. And in a parallel study, they were much more likely to have complex and intractable psychiatric disorders. So, because these experiences were in the home, these traumatic experiences, household member with a mental illness, maltreatment, domestic violence, substance abuse in the parent, things that really provide a toxic environment for the child, the most effective dyadic interventions really need to incorporate attention to what happened to the child and what happened to the parent to understand the roots of emotional illness. Naming and acting to alleviate what children and parents fear is at the core of resolving mutual blame, guilt, anger, and mistrust that result from unsuccessful efforts at self-protection. Pre-verbal and verbal and barely verbal children tell us through their play and their behavior what they need. The timing of their tantrums, their sleeping problems, their feeding difficulties, their approaching or running away from the parent in uncertain, unfamiliar situations, all of these give us cues about how to help them create a protective narrative where the parent can use touch and holding and play and words and singing and dancing and humor and peekaboo games and hide-and-seek games and bubble blowing, anything that helps to create in the child a sense of safety and trust. In this process, the intervener needs to be as empathic to the parent as to the child's emotional experiences, because it is only when the parent feels profoundly met and supported by the therapist in her own needs that therapeutic progress on behalf of the child can occur. This is because the roots of young children's emotional problems often go back to the parents' experiences while growing up. We know that current poverty and current adversities make it difficult to shield children from stress. And the prevalence of child abuse certainly goes up, and it went up in the last economic downturn. But the danger to children's physical and emotional health increases exponentially when the parents' own painful childhood experiences distort their perception of what the child needs. There is an intergenerational transmission of adverse reality and negative emotional experiences. When we ask parents about their own experiences while growing up, we often find an eerie similarity between their own experiences and how they are now raising their child. And we describe this repetition of the past in the present as ghosts in the nursery, the parents' haunted childhood, making a reappearance now in their feelings towards their child, who is essentially pressured by the parents' behavior towards them to reenact the negative expectations of the parent. And I will give you an example. The mother of an almost 3-year-old called Joel brought him to treatment because he was so aggressive and dysregulated that he was about to be expelled from preschool. And essentially, the teachers gave this mom an ultimatum. Either send your child to treatment, or we will need to ask you to find another childcare. The mother described Joel on the phone as hell on wheels. And as they came in, both the mother and Joel were dressed in black leather jackets with skulls and bones on the back. They both had nose piercings, and they both had green hair cut in a punk style. This mom was unconsciously showing us that her child was a mirror image of herself, and she was teaching him to be like her, while simultaneously telling us that he was hell on wheels. When Joel first saw the therapist, he moved closer to his mom and hesitated to come into the playroom. Completely normal behavior for a 3-year-old, and actually a very reassuring demonstration that he kind of relied on his mom for a sense of safety. But his mom, instead of reassuring him, pushed him ahead, saying, "Don't pretend to need me." And then turned to the therapist and said, "He's a manipulator. He just pretends to be scared." This child's nails were beaten to the roots. He woke up crying every night, and he clung to his mother before she left him in childcare, only to become aggressive and out of control with his peers and the teachers after she left. His anxiety went unrecognized by the adults, who could only see him as an aggressor, instead of understanding his hitting as an effort to protect himself from what he perceived as an unpredictable, dangerous social world. Now, to help children like Joel, we first need to learn what happened to them. And then we need to help them and their parents create corrective experiences of reciprocity and protection, what we call angels in the nursery, or good memories that counterbalance the ghosts. Bowlby wrote that children become emotionally disturbed when they are expected to keep secrets, when they know what adults don't want them to know, and they feel what adults don't want them to feel. When the therapist asked Joel's mom about how she grew up, she for the first time started talking about experiences of being left alone, being harshly scolded, being punitive, that revealed the helplessness and the hopelessness under her in-your-face green hair and nose piercings and black jacket. And when the therapist gave words to the pain and injustice of how she was raised, the mother started crying convulsively and said, "I don't want to hit Joel. I know he's only a little boy, but I can't help it." And this gave us a sense, because we did not know she was hitting Joel, to the origins of Joel's aggression and anxiety. And when the therapist turned to Joel, she said, "Your mommy told me that she sometimes forgets that you are a little boy and hits you when she's mad at you. You get so scared and you can't sleep and you bite your nails and then you hit at school. She wants help so you and your mommy don't get so angry and scared and can have a good time together." And this little boy, not yet 3, came very close to the therapist, looked deeply into her eyes, and then suddenly slapped her. The mother yelled in a mixture of shame and anger and helplessness, "Don't do that. I told you, he's bad. Nothing will help." And the therapist took Joel's hand gently and said, "Ouch, that hurt. You are showing us what you need help with. Sometimes you can't stop yourself, but your mom and I will help you learn not to hurt." This reframing spoke simultaneously to the mother and to the child. The mother said, "You mean he was trying to tell you something?" And this was the first inkling that his hitting might be an effort at communication, and that her hitting was teaching him how to hit. And the mother then said to Joel, "I don't like it when you hit." And Joel, at age not yet 3, had the gumption to say, "You hit me, Mommy." And the mother was speechless. And this is when the therapist came in protectively, both for the mother and to the child, saying, "Your mommy told me she doesn't want to hit you because she loves you. We will all learn not to hit." And she was making herself a partner in this protective narrative. And we find that addressing the pain and the call for help under unmodulated behavior is often the first step towards healing. Now, the treatment that I've been describing is child-parent psychotherapy. It is a treatment that has been found effective in 5 randomized studies with more than 500 children of all socioeconomic status and all ethnicities. But given the high prevalence of adversity and trauma exposure, we need more than treatment. We need to create partnerships. We need to create teams where nurses, social workers, childcare providers, OBGYN, pediatricians all come together around the question of how can we find out what happened to this child and what happened to this parent, and how can we replace the question, what is wrong with this child, with the question of what happened to this child and parent and how can we help. Right here in LA, there is the National Child Traumatic Stress Network that is creating systems of care that help primary care providers, child care providers, and others that care about young children create avenues of communication. And at UCSF, we are providing primary care mental health collaboration in pediatric clinics, in the women's clinic, in OBGYN, and mental health consultation in childcare, so that we can all come together in this joint goal of protecting children through protecting and helping their parents. Thank you very much.